Hello, and welcome to our presentation for a new healthcare system. Today in our
We would like to
PowerPoint,
call our
we
new
will be
healthcare
discussing
system
a number of
AmeriCare.
things, healthcare for the
Here is
whole
our agenda.
American. Questions:
There
why
are a
we need a
number
new
of
healthcare
challenges in
system,
the current
American healthcare
challenges.
system. Eligibility
We
and
have a
enrollment,
few that we have found
AmeriCare
to be
coverage,
most popular
technology,
amongst Americans today.
learning from other
Things like
countries'
wait
new
times,
implementations,
cost,
limited
barriers,
number of
and cost.
specialists, limited English proficiency, health detriments, and healthcare access. So we needed to come up with a purpose. Our design is one that plans to improve the access, affordability, and quality of care with focusing on cost, coverage, and delivery. There are over 30 million people uninsured in America today. Things like medical bankruptcies and high cost per capita add to the anxiety that surrounds the thought of healthcare. There are also things like health disparities by race, income, and geography. It just doesn't allow every American to have an equal amount of healthcare. This is what we wanted to focus on. How do we improve these things?
This chart shows where our healthcare dollars go today. Prenatal care runs just about 66.6 billion annually, while care for children 0 through 17 runs around 398.8 billion. Young adults 18 to 26 account for 240 billion, but spending jumps dramatically in the 27 to 64 age group to 1.64 trillion, in part because this band makes up almost 50% of the population. And seniors 65 plus total at 1.22 trillion. Most of our spending is concentrated later in life, while early life care, where prevention has the greatest long-term payoff, represents a much smaller share. AmeriCare aims to rebalance this by investing more in the prevention and efficiency of every stage of life. AmeriCare offers universal coverage for all U.S. citizens and legal residents, ensuring no one falls through the cracks. Enrollment's automatic at birth or upon gaining legal residency, streamlining access and removing any administrative barriers. We've broken our population into three key bands to better understand and manage costs. For ages 0 through 17, this group includes over 76 million children and includes nearly 3.7 million births per year. They will receive full medical, dental, and vision coverage under AmeriCare. For ages 18 through 64, with over 199 million adults, this population will be enrolled in AmeriCare for preventative care, including medical checkups, dental cleanings, and vision exams. For hospitalization and surgery, we highly encourage the use of optional catastrophic plans with income-based subsidies and deductible caps. And for all of our patients and members aged 65 and above, covering nearly 60 million seniors, this group will transition into fully comprehensive universal coverage under AmeriCare, absorbing and expanding the current Medicare structure. To make this transition work, we've mapped out a 5-year rollout plan. During this period, private insurers will continue to operate, but Americare will gradually start to take over primary coverage responsibility for all eligible residents, particularly for preventative and essential care. This phased approach will ensure that there's stability and it protects provider networks and gives families and businesses time to adapt. The end result, a streamlined enrollment, consistent care, and long-term cost control across the healthcare system. So, what exactly will AmeriCare cover? Well, let's start with the foundation. Universal comprehensive coverage. It isn't just insurance, it's access to care that you can count on. First, preventative care is fully covered for everyone. That means annual checkups, vaccines, cancer screenings, the kind of care that keeps people healthy and lowers long-term system costs. Primary care is at the heart of our system, with a strong emphasis on the provider-patient relationship. When the unexpected happens, emergency and hospital services are covered for for our pediatric plan and for our senior plan. Whether it's a broken arm or major surgery, AmeriCare has you protected. We're also including mental health and substance abuse care as core services, not as optional add-ons, but as essential care. Vision, dental, and hearing will also be included in two ways. For children, it's fully covered. For adults, annual exams are covered with the optional private upgrades available for things like glasses or restorative dental work. And for seniors, this service will also be covered. For children, AmeriCare provides full comprehensive coverage to give every child the healthiest start in life. Preventative medical care, including annual checkups, screenings, and vaccines, are fully covered at 100%. Catastrophic, hospitalization, and surgical needs are also fully covered, so families are never left with devastating medical bills. Every child receives a fully covered annual vision exam and dental care, including exams, x-rays, and cleanings. It's also fully covered. For eyeglasses or contact lenses, basic coverage is provided up to $450, with any additional cost paid out of pocket. Any restorative dental work beyond the standard annual visit is covered up to $900 per year. And when it comes to prescription drugs, AmeriCare covers them in full, ensuring no child goes without the medications they need. For adults, AmeriCare focuses on keeping people healthy while providing strong coverage for the essentials. Preventative medical care, including annual checkups, screenings, and vaccines, are fully covered at 100%. Catastrophic hospitalization and surgical coverage is encouraged to be purchased through AmeriCare Expanded, giving individuals flexibility while keeping base costs lower. Annual vision exams are fully covered, as are dental exams, x-rays, and cleanings each year. Eyeglasses or contact lenses, as well as any additional dental work beyond the annual visit, would be paid out of pocket or through an optional private plan. And again, prescription drugs are fully covered, ensuring adults can access their medications without financial strain. For seniors, AmeriCare delivers the most comprehensive coverage, recognizing that healthcare needs often increase with age. Preventative medical care, annual checkups, screenings, and vaccines are fully covered, as is catastrophic hospitalization and surgical care. Annual vision exams and dental checkups are included, as well as x-rays and cleanings, and they're fully covered. Eyeglasses or contact lenses are covered up to $450, with any remaining cost out of pocket. Additionally, any restorative dental work beyond the annual visits are covered up to $900. And just like with all other age groups, prescription drugs are covered in full, ensuring seniors can access the medications they need without cost being the barrier.
Prescriptions are things that just about every American has to have. Everybody knows somebody that is on some type of drug that they have to take constantly just to keep them alive. Americans currently pay over 200% higher for prescriptions than any other country. We spend $600 billion in prescription costs every year. So, why does it cost so much for prescriptions? Well, research and development, for one. It takes a very long time to get the money, to do the research, to get approved by the FDA. It's a very long process. The next thing, lack of price negotiation. Later on, we'll discuss things that we have taken from other countries, and this here is one of them. So, in America, Medicare, Medicaid, they are not allowed to negotiate the price with pharmaceutical companies on the price of a medication. Next thing is patent protection. If you don't want your formula for your drug to be stolen, you have to pay a high cost. But the person who made that cost, they need that money back. So the only way for them to make that money back is to increase the cost of the actual drug to the consumer. Next is marketing and advertising costs. Commercials that we see on TV are not cheap. They cost money. And so therefore, once again, The person who created this formula for this particular drug, they have to make their money back. Next on the list is complex supply chain. We have a middleman that we have to go through. What happens if you get rid of that middleman? What happens if you deal with the supplier directly? You could lower the cost. And the last item is regulatory environment. Who is in charge of placing caps on the cost of medications? There is no one here in America that does that. A pharmaceutical company could charge anything, and they do. And that is the reason why we pay so much more higher for prescription costs here in America. In the previous slide, we discussed how much Americans pay for prescriptions every year, and we discussed why those costs are so high. Here, I've taken pieces from other countries and what they do to bring it into play for our new healthcare system. So, how can we lower the cost of prescriptions? The first thing would be the research and development costs, not charging pharmaceutical companies so much to do their research. The next thing is government regulations on what pharmaceutical companies can charge. The thought is that maybe they should not be for profit, or maybe we should cap the cost. You cannot go any higher than this amount. Next things Next thing on the list is limit the number of buyers in the country. This goes back to when I said eliminating the middleman in the previous slide. If we could go straight to the pharmaceutical company to buy our medications and not go through a middleman, we would not have such high costs for prescriptions. The next thing was something that I found to be very interesting, which is the negotiation of pharmaceutical companies' costs between Medicaid and Medicare. So, right now, there's a law that says that Medicare cannot negotiate with pharmaceutical companies for the price of prescription drugs. However, the VA is allowed to negotiate. And because they are allowed to negotiate, prices for veterans are 10 to 20% cheaper. That is a large cost. Our next item would be something that Germany does. They created a nonprofit health insurer. So the group that does the insuring, it's not for profit. They do not take any money just for their own. They do not pocket it, so to speak. Our next item comes from Canada, our neighbors up north. In their healthcare system, there is a non-government drug review board. Buyers don't have to accept the cost of a drug, and companies are forced to lower their cost. A good example of this was there was a chemo drug that was non-formulary in a Canadian hospital. The drug cost an extreme amount of money that the patient just could not pay for it. So the hospital went to the pharmaceutical company, and because they have a non-governmental drug board review board, they are allowed to negotiate the price. When the pharmaceutical company refused to lower their costs, the hospital dropped out. They said, okay, fine, we'll go somewhere else. Due to the fear of losing profit, the company dropped their price. And other hospitals started to follow suit. They realized that they had the control, they had the power. Here in America, the pharmaceutical drug companies have the power. That needs to be changed.
A key ingredient for AmeriCare's success will need to be the focus on patient-centered care. This emphasizes the involvement of patients in all aspects of their health care, ensuring that care is tailored to individual patients' preferences, needs, and values. Primary care is the cornerstone that serves as the platform for implementing patient care effectively, particularly in preventive care, chronic disease management, and ongoing patient relationships. High quality patient centered care improves the health outcomes, enhances patient satisfaction, and reduces hospital readmissions. Core components identified include respect for the patient values, coordination of care, communication, emotional support, and access to care. These elements are best delivered through a well developed primary care system. Telehealth has emerged as a transformative tool, especially during the COVID-19 pandemic. Telehealth aims to extend primary care to underserved and rural populations. It addresses geographic and resource barriers, ensuring timely and consistent access to health services. Telehealth directly supports this by reducing the burden of travel for rural patients, providing ongoing monitoring for chronic conditions, offering real-time consultations and follow-ups. Telehealth also supports patient empowerment and self-management, which is a key ingredient in the patient-centered models. Community health partnerships are essential in patient-centered care, especially for chronic conditions requiring coordinated, continuous care. A case study from Kenya described by Van Edel et al. Describes how blending patient-centered care delivery and innovation financially and locally with partnerships can strengthen health systems. In Kenya's integrated model, community health workers, local clinics, and non-governmental officials, such as the nonprofit organizations, worked collaboratively. Patients received tailored chronic care with consistent follow-up and education. A shared digital health infrastructure enhanced care coordination and data tracking. This approach is highly adaptable to other contexts, including rural and underserved areas in the U.S., where community health partners can provide culturally competent care, improve outreach engagement, and enhance trust and continuity in care delivery. So, in conclusion, integrated health centered principles into primary care, leveraging telehealth, and engaging in community health partnerships are critical steps towards a more equitable and effective healthcare system in the AmeriCare system. Advancements in health technology will be needed to transform AmeriCare's healthcare delivery, particularly in managing chronic diseases. Advancements in electronic health records, or EHRs, AI for risk assessment and diagnosis, wearable technology, and mobile health apps are a big piece of the transformation. The use of a nationwide EHR system will create a unified platform that allows patient data to be accessed across different healthcare providers, thereby enhancing continuity of care. When integrated with AI-driven analytics, EHRs enable predictive risk modeling and diagnostic support, ultimately improving clinical decision-making. According to author Joe Paul, AI can analyze massive streams of health data from EHRs and wearable devices in real time, allowing for early identification of chronic disease progression and the personalization of care pathways. Additionally, AI algorithms can flag abnormalities or risk factors that may go unnoticed during traditional clinical visits and enable proactive intervention. Joe Paul's 2021 study on integrating AI, blockchain, and wearable tech also emphasizes that AI-powered EHR systems can reduce diagnostic errors, optimize resource allocation, and support evidence-based care by correlating patient history, biometrics, and population-level data. Wearable technologies such as smartwatches, continuous glucose monitors, and heart rate trackers play a vital role in real-time monitoring and personalization of chronic disease management. Joel Paul highlighted how AI-driven wearables provide real-time feedback on health metrics, supporting early detection and timely intervention. These devices are especially useful in managing chronic conditions such as diabetes, hypertension, and heart disease by offering non-invasive continuous monitoring that informs both patients and providers. The 2021 Integrated Tech Study supports this by outlining how wearables, when combined with AI and blockchain, ensure secure, tamper-proof health tracking and enable decentralized yet coordinated care. This empowers patients to take a more active role in managing their health and reduce reliance on in-person monitoring. Mobile health applications enhance the patient's experience by allowing users to view the medical records, schedule appointments, receive medication reminders, and communicate with their providers. These applications act as a central interface for personal health management, integrating data and wearables and EHRs while presenting it in a user-friendly format. Joe Paul notes that the functionality promotes patient engagement and adherence. Incorporating blockchain technology can also ensure that the privacy of the patient's personal health data across platforms are all secure.
This chart breaks down AmeriCare's projected annual cost by age group. Starting on the left, prenatal care, covering births each year, comes in at $66.6 billion. This ensures that mothers and newborns receive essential care from the very beginning, preventing costly complications later on. For children aged 0 through 17, the cost is $398.8 billion. Under AmeriCare, all care for this group is fully covered, supporting healthy development and reducing long-term healthcare needs. Next, for young adults aged 18 through 26, the cost drops significantly to $73.8 billion. This group is generally healthier and primarily needs preventative care. For working-aged adults 27 through 64, AmeriCare's focus is on preventative services, which brings the group's total cost to $343.3 billion, a fraction of what's currently spent under today's system. And finally, the largest portion of this budget is for seniors aged 65 and older at 1.2 trillion. This group naturally requires more healthcare services, and AmeriCare ensures that all necessary medical care, prescription drugs, and long-term support are fully funded. By aligning the coverage with actual health needs of each band, AmeriCare delivers the universal coverage while using resources far more efficiently than the current system.
Social detriments of health, SDOH, are non medical factors that affect health outcomes. Things like economic stability, education and access, healthcare quality and access, neighborhood and built environment, social and community context are all things that have the ability to affect your health. Do you have the money to pay for health care? Were you ever taught what health is? What are healthy things to do in life? How to purchase healthy groceries when you go to the store? What is healthy versus what is not healthy? Where you grew up? Did you grow up in an environment where people didn't believe in going to the doctor because they didn't trust doctors? Did you grow up in an environment where you didn't go until you absolutely had to? Did your family believe in maybe, when it's your time and you don't need to worry about the science aspect of it? These are all things that fall into place here. So, housing and food and transportation are all things that need to be addressed. Another thing that needs to be addressed is the cultural competency training for providers. Does your provider understand why you maybe don't trust medical professionals? Language is something that many people don't even realize can cause so many issues in healthcare. There are 6,500 languages in the world. 430 languages are spoken in the US alone. In the US, we speak the most languages for one country. 26 million adults have a limited English proficiency, which is abbreviated as LEP. And LEP can cause a number of things. It could cause a misdiagnosis, misunderstanding of discharge orders, late stage diagnosis, all of these things. They also, people who have an LEP or are considered to be part of that group have longer lengths of stay and readmissions. They also have medical errors in their charts because they just cannot communicate the information accurately, which leads to the next item. Inaccurate communication of medical history, symptoms, and medical concerns are all things that lead to a misdiagnosis. We need to figure out a way to increase the amount of adults that can speak English or come up with a better translator process. Most hospitals do have medical translators and interpreters. That also includes sign language to make sure that language services are accessible to their patients. However, this still continues to be a problem in hospitals today.
One of the biggest concerns people have when they hear about a national healthcare plan is cost. Not just how much it will take to start, but how we'll keep it sustainable over the long term. AmeriCare's cost control strategy focuses on four key pillars. First, administrative efficiency. Right now, the US spends over $812 billion annually on healthcare administration. That's more than double what other developed countries are spending per capita. By consolidating billing, insurance processing, and provider contracting under one streamlined system, we can cut out administrative waste by at least 74%, freeing up hundreds of billions of dollars each year for direct patient care. Second, prevention before crisis. AmeriCare fully covers preventative services like screenings, vaccines, and wellness visits. Early detection and prevention reduce the need for expensive emergency and hospitalization care, which is where costs skyrocket. Every dollar spent on prevention can save up to $3 in future medical costs. Third, negotiating power. We'll use the buying power of 330 million Americans to negotiate directly with pharmaceutical companies and medical device manufacturers, just like the VA does today. This alone could save over $100 billion annually in prescription drug spending without cutting access. Fourth, smart payment models. We'll incentivize quality over quantity. Instead of paying providers solely based on the number of services they deliver, AmeriCare will reward them for keeping patients healthy and avoiding unnecessary procedures. This value-based model has been proven to lower costs while improving outcomes. These strategies together create a system that not only funds universal care, but actually reduces costs over time, meaning we can all eventually scale back some of the initial funding mechanisms without jeopardizing care quality. Let's talk about something that usually seems impossible in American healthcare, lowering costs while actually improving care. Under AmeriCare, it isn't a dream, it's a plan. We've already talked about the administrative savings, but it truly is the quickest way to cut down the cost by enabling a direct provider payment platform. Second, preventative care works. By fully covering screenings, vaccines, and annual wellness visits, we reduce the number of people showing up in the ER with late stage illnesses. Preventative care is cheaper than crisis care. It's that simple. Next, we tackle drug pricing. AmeriCare would negotiate directly with pharmaceutical companies, just like the VA does, and they pay up to 50% less than what private insurers pay. Centralized negotiation equals better prices and lower prescription costs across the board. Now, let's take a look at some of the different funding mechanisms. Here's how AmeriCare is funded. Our total estimated annual revenue comes in at just over $2.1 trillion, and we built this using a balanced mix of cost savings, fair taxation, and targeted contributions. The largest single source is the savings from administrative costs, $600 billion a year. By streamlining the fragmented insurance system into AmeriCare, We eliminate the redundant billing systems, overhead, and profit margins that currently eat up resources without improving care. Next, we have several targeted taxes that focus on fairness and sustainability. We'll also do a securities buyback tax of $20 billion, which ensures corporations reinvest in people, not just stocks. Reallocating existing federal Medicaid and CHIP funds for children and young adults brings in $100 billion without raising new taxes. A digital services and luxury goods tax brings in $25 billion, ensuring high-end consumption and global digital services contribute their fair share. Closing corporate tax loopholes adds another $150 billion. Enacting a carbon tax of $250 billion serves a dual purpose, funding healthcare while incentivizing cleaner energy. We'll also leverage the state matching funds of $100 billion and a financial transactions tax. At 0.5%, it generates $387.5 billion by applying a tiny levy on a large-scale trades in stocks and bonds and derivatives, as well as cryptocurrencies. On the patient side, a modest $25 outpatient copay contributes to $25 billion, ensuring everyone has some skin in the game while keeping care affordable. We had a corporate windfall tax for $125 billion to capture any excess profits from industries benefiting disproportionately from high market conditions. And finally, a wealth tax on ultra high net worth individuals bringing in $350 billion annually. Together, these funding sources give Americare a stable, diversified revenue stream, enough to fully fund universal coverage without placing the burden on working and middle class Americans. Negotiating with Big Pharma. Well, Benita had summed up a lot of it in the beginning, but now we're going to take it a step further to make sure that we enact some of those cost-saving measures. Prescription drugs are one of our biggest healthcare costs, and Americare is going to change that by negotiating directly with pharmaceutical companies for fair prices. If they refuse, we'll use the Bayh-Dole Act, a law that lets government step in when drugs developed with taxpayer-funded research aren't offered on reasonable terms. Our plan is simple. If you don't negotiate, we're going to enact the following. New grant rules. Any company taking NIH, NSF, or BARDA funds must agree to Americare price negotiations. A sunset on existing grants. Current recipients get 24 months to comply or lose federal funding. Third, Innovation Fund. Any money pooled from non-compliant companies will go to universities for drug R&D. So in short, work with us for fair prices, or we'll invest in research that puts patients first. As with any major policy shift, we know Americare won't launch without resistance, but we're ready to face those barriers head on. First, political opposition. Healthcare reform is one of the most polarizing issues in America, but here's what cuts through the noise. 70% of Americans support some form of universal health care. By showing the numbers, the savings, the coverage, the outcomes, we can reframe this as a smart investment, not as a partisan gamble. We're focusing on the economic sustainability, not just the ideology. Second, provider buy-in. Any successful healthcare system depends on doctors, nurses, and frontline staff. Our plan doesn't push them out, it brings them in. By simplifying the administrative processes, reducing billing burdens, and paying providers fairly and predictably, Americare helps restore what many clinicians say they're missing today: time to care. And finally, misinformation. We've all seen it. The social media post claiming government-run healthcare means long lines, poor care, and lost freedoms. Our job is to fight fiction with facts. The truth is, countries with systems like Americare consistently outperform the US on outcomes, access, and cost. The plan is built for health, not bureaucracy. So yes, the barriers are real, but so's the momentum. We just need the political courage and public trust to push through. While Americare fully covers preventative medical care, annual vision and dental exams, and prescription medications for adults, hospitalization, catastrophic, and surgical coverage would be available as an optional add-on through Americare Expanded. We've built flexibility into this coverage with 4 deductible options: 2,000, 3,000, 4,000, and 5,000, allowing individuals to choose a level that best fits their needs and budget. Monthly premiums would range from $525 at the lowest deductible down to $360 at the highest deductible. These plans could also be employer sponsored, giving companies the ability to provide robust coverage to their workforce. To encourage participation, corporations that fund AmeriCare expanded for their employees would receive corporate tax breaks. This not only helps businesses financially, but also ensures their teams have access to affordable hospitalization and surgical care. Ultimately, this approach gives adults the freedoms to choose between the level of coverage while keeping costs manageable and strengthening the overall AmeriCare system. Now, there's an eligible population of 163 million adults. And the idea is you're not going to get typically more than 25% to join the plan. But even at 25%, it helps fund enough so that we can provide the care needed to take care of the adults enrolled in the policies.
Estimating the precise cost savings of a patient-centered healthcare system over a 10-year period is challenging, as the savings depends on various factors like the specific implementation model, patient population, and initial investment. However, various studies and analysis offer significant insights. A New England Journal of Medicine analysis projected that adopting a system of patient-centered medical homes for primary care in the U.S. could save Medicare alone $194 billion over 10 years. One study found that patient-centered care was associated with a decrease in healthcare utilization and lower total annual charges. A recent analysis suggested that simplifying administration in the U.S. healthcare system could save an estimated $265 billion annually, which equate to roughly 2.65 trillion over a 10-year period. Shifting care from hospitals to alternate sites using existing technology could lead to an annual savings of 113.8 billion to 147.7 billion. This could translate to a significantly larger saving over a 10-year time frame, especially if technology advances as projected, potentially reaching annual savings of $208 billion to $303 billion. Some analysis focus on single-payer systems, often incorporating patient-centered principles. These indicate a substantial savings. For instance, the McCaddis Center, a conservative think tank, found about $2 trillion in net savings over 10 years from a single-payer Medicare for all system, according to The Hill. It is important to note that these are projections and estimates. The realization of these savings depends on the effective implementation of patient-centered care principles, including focusing on preventative care, early intervention care, care coordination, reducing unnecessary tests and procedures, and patient cooperation.